Very good morning to all. I'll be presenting our study on comparing the retinal nerve fiber layer and Brooks membrane opening minimum rim width measurement thickness between the glaucoma and this suspect patients using OCT. We know that glaucoma is a progressive optic neuropathy where there occurs the loss of retinal ganglion cells and the thinning of the retinal nerve fiber layer. And this cell death occurs even before it's apparent to the patient in terms of visual damage. So we have found the new parameter, that is the Brooks membrane opening minimum rim width measurement, can be an indicator of glaucomatous damage as well. So the purpose of our study was to measure the retinal nerve fiber layer thickness and Brooks membrane opening and minimum rim width measurement on OCT in this suspect's patient and then compare it with the glaucoma patients. And also to find out the association of intraocular pressure and visual field changes with these OCT parameters. It was a prospective study. It was conducted over 12 months. We took 87 patients in the glaucoma group and 88 in the dysuspect group. A comprehensive ophthalmological examination was done for all. Dysuspect patients were defined as patients which had a cup disc ratio greater than 0.5 and one eye at least, or a difference of 0.2 between the two groups, but they had an IOP of less than 20 millimeter. So these are our baseline parameters where there was a significant difference except for the gender between both the groups. On comparing quadrant-wise analysis of the retinal nerve fiber layer and the Brooks membrane opening minimum rim width, we found that the readings in the infratemporal quadrant and the supratemporal quadrant of the Rnflt were higher, whereas the nasal part of the disc was found to be thicker in cases of readings of the Brooks membrane opening and minimum rim width. And all the values were significant between both the groups. When we correlated the intraocular pressure with these measurements, as usual, we found that the intraocular pressure was negatively correlated, while retinal nerve fiber layer and BMO MRW measurements were positively correlated, and this value was significant. Which means that the change in Rnflt and the Brooks membrane opening and minimum rim width, the change that occurs in the value of these two parameters for a change in with the glaucoma progression is significant. Similarly, we also found similar results for correlation of IOP with these two parameters, where the values were significant for comparison between Rnfl and BMO MRW. When we compared visual field loss with both these parameters, within these suspects there was not much visual field loss. So we compared mild, moderate and severe visual field loss based on mean deviation on the visual field. And we found that the values, the difference in change from mild to moderate and moderate to severe, they were all significant in both the groups with the visual field loss. But on plotting the graph, we found that the Rnfl graph was steeper than the BMO MRW graph for the visual field change, which means that for the same visual field change, Rnfl loss was more predictable or had a pronounced change as compared to the Brooks membrane opening minimum rim width. We know that Rnfl assesses the thickness of the nerve fiber layer itself, while the smallest distance between the opening of the Brooks membrane to the internal limiting membrane gives us the measurement of the BMO MRW. So when both clinical and functional damage is correlated, the subtle glaucomatous damage in various quadrants can be picked up, because in our results we found that both the parameters, they show changes in different quadrants. It's not necessary that they find the changes in the same quadrant. And BMO MRW is also more effective in ruling out glaucoma in case of different types of discs. It has been shown in other studies. Now, taking both the values together, we can increase the specificity of the diagnosis. But if we take this or that when we are confused between different groups, maybe it will increase the sensitivity of the tests. So combining these findings with the visual field changes will improve the prognostic and diagnostic ability of the tests. These are some studies which have shown that BMO MRW is a reliable parameter which has discriminated perimetric, pre-perimetric glaucomas and is highly consistent across different examiners too. So the take-home message is, glaucoma is often diagnosed as a stage when damage has already started and is irreversible. So the ability to differentiate between healthy individuals, dysuspects and confirmed glaucoma patients is a critical aspect. So early diagnosis leads to better prevention and better prognosis. And this can be possible by incorporating Rnfl, BMO MRW measurement and visual field changes together. So incorporating it into our daily practice will help not only differentiate it from other optic neuropathies, from glaucoma, but also help us prevent the visual loss. These are my references. Thank you.
So, do you think how frequent should we do it if you see once?
Ma'am, I can't hear you.
How frequent should we assess?
Ma'am, as as of now, when we conducted the study, we have been using in that the spectralis OCT. It's actually possible when you take the OCT reading, we can get the RNFL and
Mr.
the BMO
Suresh,
MRW
please on the
measurements
dialysis
side by side.
podium.
So it's possible in the same setting only. It's not a difficult thing to do. When we are ordering a OCT investigation for the patient, it can be done in the same setting when we are using the machine.
In future for mild, moderate and severe myopia also in that situation.
Yes, ma'am.
Yeah.
Some studies have shown that area of in myopic patients, if there is a greater area concern, maybe BMO MRW will be less reliable. But
Right.
when it's early damage, it can be detected early.
Thank you. Keeping the myopia epidemic in mind, I think it's a very relevant thing. Thank